Now this system, although it protects, but some problems do come up in special scenario like in transplant. What is transplant? Transplant is when any organ or organ system of the body is replaced from the similar organ or organ system from another body. Okay, so this is transplant. So basically, what I'm trying to say is in transplantation, there is introduction of other antigen or organs which have their own antigen to the human body. Now, today we will learn about the immunological aspect of two things. One is first transplant, another is what is tumor immunology or cancer immunology. So, today's topics will be we'll learn about what is transplant, the classification, we'll learn about histocompatibility, the, what is graft rejection, the type, how to prevent it, an important aspect known as the graft versus host reaction, and finally we'll learn small little bit about cancer immunology. So coming to transplant. So what is transplant? Transplant is graft. It can be called as a transplant or a graft. It means it could be cells, tissues or organs which are from one side to another. Now the donor side, what is the donor side? Who is the donor? From whom the transplant or the graft is taken. And who is the recipient in whom the graft or transplant is transplanted. Okay. Now, coming to transplant. Transplant can be classified on various methodologies. First is, it is based on the which organ that is transplanted. If it is the transplant is called orthotopic. Try to understand the meaning. Ortho means correct. Topos means position. So if any organ or graft is transplanted in its correct anatomical position, it is called as orthotopic transplant. Understood? An example would be a cardiac transplant. What would be a heterotopic? Something which is transplanted at a different site, not in the same anatomical site. An example would be a kidney transplant. Normally, we will say the kidney is in the posterior abdomen. But when it is transplanted near the where? Tell me, where is kidney transplanted? You have read in anatomy, no? Why am I saying that kidney transplant is heterotopic? Where? No idea. Another would be based on whether it's a vital or static transplant. Vital means if an organ that is essential for human life because of its physiological and anatomical function, it is called as vital transplant. However, there could be other types of transplant like static graft transplant, that is a bone transplant. Okay, it may not be active physiologically but only gives a structural base. Similarly, an arterial transplant would be a static transplant. Okay. Another important, these were the anatomical and physiological aspect of classification, but the most important is the genetical aspect of transplant. First is known as the autograft. What is auto? What is auto? Auto means self. Okay. You have heard cars are being called as automobile, they are self-mobile. So autograft means self-grafting. For example, skin graft taken from a patient from one side of the body and grafted to the other side. That would be known as the autograft. Similarly, like in this diagram, I have given an example where the saphenous vein is taken for CAB. Isograft or syngeneic graft means from if the donor and the recipient both are identical twins. Because they are identical twin, the genetic similarities are probably the highest. Okay. Now coming to two important parts, allograft and xenograft. Allograft means when The donor is not identical genetically. It could be mother, father, any relative, or could be non-related. But the donor is a human being. But if the donor is from a different species, then we call it xenograft. Now, just to make you clear, in case of autograft, there is no antigenic dissimilarity. So, do you think that the immune system will act on this graft? Now, coming to histocompatibility. Histo means what is histo? Tissue. And compatibility over here means immunogenic compatibility. So, if the graft is histocompatible, what will happen? The graft will not be rejected by the body. If it is incompatible, it will be rejected by the body. Okay. So, if it is an autograft, will the graft be histocompatible or incompatible? Compatible, because it shares the same antigen of the individual. In case of isograft, what will happen? More chances are more that the tissue will be compatible. Why? Because identical twins have much more genetic similarity. Now come to allograft. Allograft means the graft is taken from one human to other human. Now, in case of allograft, what will be the effect of histocompatibility? Will it be histocompatible or not? No. Why? Different individual. And what about xenograft? Where the graft is taken from, say, another species like a chimpanzee or other animal. Will it be histocompatible? Most probably the answer will be no, because of the huge genetic dissimilarities between the donor and the recipient. So this, what is studied, is known as the histocompatibility. It determines whether the graft will be accepted or rejected. If there is compatibility between the donor and recipient, the graft will be accepted. If it is incompatible, the graft will be rejected. In all probabilities, allograft and xenograft are histo-incompatible. Now, most of the transplants that are actually being done, most of them are allografts. Okay, especially in case of solid organ transplant. So, in case of solid organ transplant, because predominantly allografts are done, so we are studying about histocompatibility. Then, if there is a question coming that it might be compatible or incompatible, that means there must be some antigens which are predominantly responsible for the incompatibility. What are those antigens? One is the MHC, major histocompatibility molecules. The other will be the ABO and RH blood grouping system. I think you have learned about ABO and RH blood grouping in your first profession. Along with that, there will be minor histocompatibility molecules. What are these antigens? These are the peptides derived from the normal cellular proteins of the donated organ. However, because the immune response to these molecules are weak, they are called as the minor histocompatibility antigens. Another interesting phenomenon is known as the Eilbach-Schlimsel effect. What is this effect? You know the chromosome of male, it is XY, whereas female is XX. So, if an organ is transplanted from male to female, that graft will also have some protein expressed on the Y chromosome, and that would be absent in the female, which can lead to a response in the recipient. This is known as the Eilbach-Schlimsel. Now, coming to MHC, MHC is a molecule that is known as the major histocompatibility complex. Now, keep in mind that MHC naming was first done when these compatibility studies were done on mice. Similar location is seen in human beings known as the HLA. You have heard about HLA? So that is what is present in human beings. What is most extensively studied, that is known as the MHC. Okay, so we will be learning about MHC in detail to understand how HLA works. So these are present on chromosome number 6. They were first identified by their potent effect on immune response to transplanted tissue. Hence, they were named as major histocompatibility complex or MHC. The human counterpart is known as the human leukocyte antigen. It is present on chromosome number 6, human chromosome. So, if you are asked what is the main important role, your answer would be HLA, present on chromosome number 6. This is a diagrammatic representation of the MHC. It has got 3 parts, 1, 2 and 3 and there are more than 200 genes in this region. So why I am showing you this? Because of two important principal function of MHC is to hide. You know T cells are present, you have studied. Those are known as the cytotoxic T cells, CD4, CD8. Can you remember something? Those are the T cells. They help the T cells to recognize and discriminate between self and non-self. So what do you mean by self and non-self? That means these cells will not be, T cells will not show any action on cells which show self-antigen, but will act on cells which do not show self-antigen or show non-self-antigen. Understood? Now get it. The function of T cell is to recognize, differentiate between cells which are self and non-self. How it will recognize? Two ways. There might be some self-antigens. The T cells will recognize, okay, these antigens are present, that means these cells are belonging to the same individual. Or the cell may not show those self-antigens. Then it will say, okay, if this particular cell is not showing the self-antigen, it might be infected, whatever, this cell has to be destroyed. Otherwise, the cell may show non-self antigen, exogenous antigen, may be acquired from say virus or any other organism. Then the T cell will destroy that also. Okay. Now, an important phenomenon seen with MHC is it is polygenic and polymorphic. What do you mean by polygenic and polymorphic? I have already told you there are more than 200 genes. There is continuous permutation and combination going on in every level of reproduction. That means because of the polygenic and polymorphic nature of these genes, there will be multiple numerous traits. So every individual will be different from the other one on the image. Understood? If I say why, suppose you and you are different. Why? Because of the polygenic and polymorphic. There will be multiple permutation and combination. Now there are two MHC molecules. One is known as the MHC1 and one is known as the MHC2. Just a little bit about the structure. Why? Because they are important. MHC1, you can see there are 4 domains: alpha 1, alpha 2, alpha 3 and beta 2 microglobules. And MHC has alpha 1, beta 1, alpha 2, beta 2. Can you see the difference? This is the part that is different. MHC1 has alpha 3, whereas MHC2 has alpha 2. And over here it is 1 and alpha 1 and 2, here is alpha 1 beta. This is the structural dissimilarity. Why? Because of this structural dissimilarity, one will trigger what is known as the CD4 cells, the other will trigger what is known as CD8 cells. Just look at the differences between MHC1 and MHC2. Obviously, there are differences in the polypeptide chain, so the weight, but major differences are MHC2 is expressed in all antigen presenting cells, whereas MHC1 are displayed by all nucleated cells. Now, what are antigen presenting cells? Give some examples of antigen presenting cells. Macrophage, neutrophage, and anything else? On skin, it is known as dendritic cells. Okay, so if you go and study, almost every organ system have their antigen presenting cells. So those antigen presenting cells will express the MHC2, whereas all nucleated cells, when I say nucleated cells, then MHC1 is present in RBC. Is it present on? No. Is it present on platelet? Yes. Because platelet is fragmentation from megakaryocytes. Megakaryocytes have their own nucleus. Hence, it will have MHC1. So, any nucleated cell in the body, if it fails to express MHC1, it will be destroyed. Okay. Now, MHC1 molecules, they will bind to CD8 and MHC2 will bind with CD4. This is the main two part that you must remember. The T cells recognize foreign antigens, then the antigens are categorized based on from which they are derived, either viruses, bacteria, or parasites, or it could be exogenous pathogens that replicate outside the cell. Intracellular antigens are presented to the T cells by nucleated cell because of the MHC1 and its expression is ubiquitous. Ubiquitous means always, everywhere. So there will be intracellular antigen and those obtained from viruses, bacteria and parasites. Now look over here, the exogenous antigens will be taken up by the professional antigen presenting cells known as APC, which process the antigen and then present them in context of MHC2. MHC2 means CD4. So any exogenous means from viruses, bacteria, parasite, whatever it may be, it will come in contact with the antigen presenting cell processed by MHC2 and activation of the CD4. So this is the diagram. You can see CD8 is triggered by MHC1 and CD4 it is triggered by the MHC2. The MHC2 will be triggered by antigen presenting cell and MHC1 will be the viral infected cell. What happens is a normal cell will express MHC1 antigens, but when it is infected with virus, it will fail to express MHC1 molecule. Okay, then it will trigger MHC1, which will trigger CD8. This is how MHC occurs. And in human beings, the same function is done by HLA. Okay, autoimmunity class have been taken. You have learned about HLA, HLA ABC, HLA DR, DP, DQ. Now coming to graft rejection. Now the graft may be taken up, that is accepted, or may be rejected. The rejection of a graft occurs in three ways. Those are classified as hyperacute, acute, and chronic. Why I am saying this? Because there are some similarities between hypersensitivity reactions and you have learned about hypersensitivity reaction. There are 4 types of hypersensitivity reaction. What is type 1 hypersensitivity reaction? It is mediated by IgE. What is type 2 hypersensitivity reaction? Mediated by cytotoxin. Okay. What is type 3? Antigen antibody complexes. This one type 2 reaction will occur because of the antibody mediation. Okay. This is antigen antibody complex and type 4 is delayed type of hypersensitivity or mediated by T cells. Okay. So if we look at the mechanism of types of rejection, we can see that hyperacute rejection is similar to type 2 hypersensitivity. Type 3 type of reaction is seen in chronic reaction, and delayed or T cell mediated reaction is seen in acute rejection. I'll explain all type of reaction, then you can understand. First, take up hyperacute rejection. What happens is it occurs within minutes to hours of transplantation. Immediately. Okay. In any graft or transplant, the most important part is nutrition to the organ. Nutrition is provided by blood. So, maintenance of vascularity is of the first and foremost part of any transplant cell. In hyperacute rejection, there is immediate thrombosis of the graft vessels. Matlab, vessels of the graft and necrosis. This is mediated by circulating antibodies present in the recipient, and those are present before transplantation. That means not after. You will understand the similarity with, you have learned about ABO incompatibility. ABO incompatibility, blood incompatibility. What happens over there? There are preformed antibodies in the body, and if you give incompatible blood, what will happen? Those antibodies will start reacting with the blood. Same case over here. Antibodies are present within the recipient prior to transplantation. After transplantation, those antibodies will get activated and will first obscure the vascularity of the graft. Hence, the graft, what will happen to the graft? Because of lack of blood supply, it will undergo necrosis. Now, similarly, if in the same recipient another is graft given from the same donor, what will happen? The rejection will be even accelerated. Okay. So this is the pictorial diagram. You can see antibodies are present previously. They will enter in the graft. Suppose this is a kidney graft. The vessels, in the vessels, the antibodies will get attached to it. This will lead to local reaction and formation of a thrombus plug. But more importantly, hyperacute rejection is not a common problem clinically. Why? Why? Because obviously prior to transplantation, we perform what is known as cross matching of blood and HLA type. Because this is preventable. You can avoid them. This is the ABO blood grouping. You understand this? This is a potential donor of the O, A, B and AB group. These are the recipients who have the following antibodies. This is the chart, and you can see that if a person who have both anti-A, anti-B antibody like in blood group O, you cannot give AB blood group. This is the same chart you have studied. So by this, we can prevent ABO incompatibility between the graft and the recipient. So this is a diagram showing histocompatibility in blood transfusion. When you say the more compatible this is, the frequency of reaction goes down. That is, look at over here, AB and Rh positive. This is the recipient. The donor is AB and Rh positive. They will have the lowest frequency of incompatibility. That is 3.4. So in transplantation, or the donor and the recipient should be typed for ABO blood. Next comes is HL. Look at this. This is the mice which have MHC type A. Suppose type A. A skin graft is put on another mice with MHC type A. The graft is not rejected or is accepted. However, if the donor is of MHC type B and the recipient is MHC type A, what will happen? The graft will be rejected. Now let's complicate this situation a little further. Suppose the donor is of MHC type B, but the recipient has mixed MHC, both A and B. What will happen? The graft from inbred parental strain is not rejected by the Hybrid means which has both A and B. But if the donor is a hybrid and recipient is of either MHC category A or B, the graft will be rejected. Based on this principle, we can say if there is matching of MHC, you can see number of mismatches over here. The 10-year estimated life is only 17%. If the number of mismatches is 0, 10-year estimate is 33% and half-life is 13.5%. This is the half-life of the graft. Okay. If there are no mismatch of the MHC or HLA, probably 13 years would be the lifespan of the kidney graft. But if the number of mismatches increases, the half-life of the graft will decrease. Along with MHC, I have already told you there will be minor histocompatible antigen. These include the proteasome, endoplasmic reticulum of the donor tissue. This was all about hyperacute rejection. This you will not see clinically. Clinically, you will see mainly two types of rejection. One is acute rejection, other will be the chronic rejection. What is acute rejection? Acute rejection occurs in days and weeks. It is due to the active immune response mediated by the T cells and it is antibody dependent. The T cells will be cytotoxic and will induce inflammation. Also, antibody mediated complement activation will be done by the classical pathway. You have studied complement system? তোমরা পড়েছো? That says it all. So, look at this pictorial diagram. What will happen is, now in acute rejection, the antibodies are produced after the transplantation is done. These antibodies will now get engaged in the, suppose if it is a kidney graft, in the renal vessels, and in the renal vessels, it will activate the cytotoxic T cells and antigen antibody mediated complement activation. What will happen because of complement activation and activation of the cytotoxic T cells? It will be local tissue destruction. If there is local tissue destruction, what will happen? There will be inflammation. In pathology, you have read about inflammation. So, you can see there is vascularity decreases with increased inflammation and subsequently there will be necrosis. This will happen in two phases. One phase is known as the sensitization phase, other will be the rejection phase. You have studied in type 1 hypersensitivity, there will be two phases. Similarly, over here, the sensitization phase, what happens is, the donor dendritic cells will present the antigen. Antigen presented may be direct, may be indirect. Let's keep it for another time. It may be direct or indirect. These antigens will trigger the response because of the antigen presenting cells in the local lymph node. Local lymph node means from the site of the graft. It will start producing antibodies from the B cells. And along with that, it will trigger the T cells. Then the B cells and T cells will reach the graft. When it reaches the graft, the antibody will further trigger T cells and the antibody will also trigger the complement system. This is known as the rejection. Okay. Last part is the chronic graft rejection. Chronic graft rejection is the most common type of rejection that is seen. It is indolent. What do you mean by indolent? Indolent means very slow, steady and progressive. And it is manifested as fibrosis of the graft. What happened in hyperacute rejection? It was thrombosis. In acute rejection, what happened to the vessels? It will be inflammation and necrosis. Over here, it is fibrosis. Why this happens? Because the T cells that react against the graft, they secrete cytokines. Now, these cytokines lead to proliferation of the endothelial cells. Because of the proliferation, now the vessel wall will be thickened. This is known as sclerosis. If it affects the arteries, we call it arteriosclerosis. This is the pictorial diagram. You can see because of the T cells, a number of cytokines will be released, and because of these cytokines, there will be inflammation within the vessel wall, leading to thickening of the vessel wall, and it makes the vessels less compliable. Compliable means exercise. So let us revise these three types of rejection. Hyperacute rejection is mainly by ABO or anti-HLA antibody. It occurs within minutes to hours. Acute occurs within weeks to months. It is mainly mediated by cytotoxic T cell and antibody mediated. Whereas chronic is mediated by chronic delayed type of hypersensitivity. Now you can see why initially I compared types of rejection with hypersensitivity. Okay. Now coming to factors influencing graft rejection. What will be the factors influencing graft rejection? First will be the tissue involved. As I have already told you, solid organs, they have their own dendritic cells. Hence, it will indirectly trigger the immune response. It is similar to that, but it is not exact. This type is mainly by antigen antibody complexes. In case of hypersensitivity, is similar to serum sickness. If you read autoimmunity, it will see like SLE, a number of autoantibodies are seen. So, coming to the factors influencing the transplant, first will be the organ. What is transplant? If it is a solid organ, then it will have its own antigen presenting cell. So, there will be indirect stimulation of the host or recipient immune system. And if the organ system is devoid of antigen presenting cell, the indirect trigger will be less. It will be less immunogenic. Next comes the genetic distance between donor and recipient. I have already told you, the more genetically different they are, the more chances of reaction. Finally is the immunological memory of the recipient. What do you mean by immunological memory? If the recipient is immune compromised, say they have no immunological memory, will the recipient act on the graft? There will be no rejection. Understood? So, but if the recipient have a very high immunological memory, the chances of rejection will be. Now let us take a very simple example of how a graft is taken. You will also study this in pathology. I am just giving a brief idea. It is an autograft acceptance where a skin graft taken from the same individual is transplanted to a different part of the same individual's body. You will see within 3 to 7 days there will be revascularization and complete resolution will be seen in 2 weeks time. This is the normally what happens with autograft, means there is no antigenic descent. But when we look at the allograft, that is, if the graft is taken from another human being and transplanted to another human being, you can see revascularization takes place within 3 to 7 days. But after revascularization, there is triggering of the immune response with cellular infiltration, and necrosis and thrombosis will be seen by 2 weeks. That means if there is no immunological reaction by 2 weeks, if it is an autograft, complete healing will be there. But because it's an allograft, because of the immune response, within 2 weeks, you will see thrombosis and necrosis. Again, if another graft from the same donor is put on the same recipient again, that means recipient's immunological memory has already been triggered. After that, if the graft is presented, you can see within 3 to 4 days, even before revascularization, there is cellular infiltration. And the rejection will be within 1 week. This is just an example with skin. This is the overall mechanism of graft rejection. You can see this diagram. There is, if this is the graft, it will express the MHC expression, and the donor MHC will trigger the T helper cells by delayed type of hypersensitivity. There will be expression of enzyme cytokines. By triggering of the CD8 cells, there will be membrane damage, direct toxicity. Again, because of the antibody by the T helper cells will stimulate the B cells, they will produce complement mediated lysis, and this is known as the antibody dependent cell cytotoxicity, ADCC. I think this is a bit confusing for you all because you have not read immunology at all. This has all been taught you in process, but you haven't. Now coming to the important question, how can we prevent graft rejection? Graft rejection can be prevented by, very commonly, if you test for the ABO incompatibility, if you test for HLA incompatibility, you can avoid hyperactive rejection. HLA typing can be done by phenotypic or genotypic method. There are many phenotypic methods like microcytotoxicity or mixed lymphocyte reaction. Don't get into the details, just remember two types of typing should be done, ABO compatibility typing and HLA typing. That should suffice. And it can be also done genotypically. Other important part is immune suppressive therapy. It is the immune system which is acting on the graft. If we use immune suppressive therapy, the graft rejection can be delayed. In case of hyperactive rejection, there is only one method of treatment, that is removal of the graft. There is no other one. It is so rapid. In chronic rejection, treatment is generally not conducive because it is a slow and progressive, it will go on like non-communicable disease. So what is the main modality of treatment is retransplantation after end of half or some drugs are under trial. So as you can see, immunosuppressive therapy has a major role to play in acute rejection. Now what are the immunosuppressive drugs? First is corticosteroids. You already know steroids can inhibit all immune reactions along with calcineurin inhibitors like cyclosporine, tacrolimus, mycophenolic acid like antiproliferative and mTOR inhibitor like sirolimus or everolimus. I am not going into details of these things. You will read in pharmacology and respective clinical subjects as well. Another important part of immunosuppressive therapy is known as the monoclonal antibody. I have already shown you the chart where each and every cytokines and cell mediated reaction is occurring. Any antibody which inhibit those reactions can be used for inhibition of the immune response. There are many such reactions like infliximab, which is inhibitor to TNF alpha, CD20 inhibitor like rituximab. This was all about solid organ transplantation. One other important transplantation is known as the bone marrow transplantation. So what happens in bone marrow transplantation is there might be some pathology in the hematopoietic cells of the patient, because of which they has to be changed. There are many diseases you can see, more importantly are the leukemic causes, more common indications of bone marrow transplantation. Now over here, till now, in all transplantation, we have understood is because of the immune system, the recipient's body act on the graft. But in bone marrow transplantation, what is done is, first, because of radiation and chemotherapy, all dividing cells in the marrow are killed in the patient. Okay. Then hematopoietic cells are transfused into the patient. This is very simple, bone marrow transplantation. Why? If you give IV, any stem cell, it will go and lodge in the bone marrow. Problem over here is, now the recipient does not have any immunological cells. All the immunological cells are coming from the donor. These cells will now act on the recipient's body. Earlier, what was happening was, the recipient's immune system was acting on the graft. Over here, what is the graft? It is the hematopoietic cells. They will start acting on the recipient. This is what is known as the graft versus host disease. So, graft versus host disease is the graft, that is the transplanted cells. They will mount an immune response against the host. When it will occur, কি ভালো লাগছে না? You can go. If anybody at any point of time feel that this is uninteresting, this is not required, you can leave. I have no objection. Give your attendance and leave. But please do not disturb. So when will this graft act on the recipient body? First of all, it must have immunological cells. This is known as the graft must contain immune competent T cells. Why competent? Because it can mount an immune response. So, for graft versus host disease, there are three primary requisites. First, the graft must have immune competent cells so that it can mount an immune response. And the recipient must be devoid of any immune competent cells. Otherwise, the recipient will also mount an immune response. And finally, the recipient should possess transplant antigens that are absent in the graft. Then only the mismatch will occur. So, the graft should have immune competent cells, the recipient should be devoid of immune competent cells, and the graft should have antigens which are not present in the recipient. If these three criteria are fulfilled, then only the graft will mount an immune response on the host. This is seen in bone marrow transplant, where complete bone marrow is transplanted. You will go and read where are the B cells and T cells. You can see that B cells also reside within the bone marrow, both T cells. So, after the allogenic hematopoietic stem cell transplant, these transplanted cells will then move into the lymph nodes of the recipient and will trigger immune response, both production of antibody and initiation of cytotoxicity. Then what will be the types of reaction? It could be acute, it could be chronic. Medically, it is defined as any reaction that occurs within first 100 days of bone marrow transplantation, we call it as acute. And if it occurs after 100 days, we call it as chronic. Furthermore, you will go and study within these 100 days of transplantation, the recipient is particularly susceptible to a number of infective conditions. Thereby, within these 100 days, those patients should be carefully monitored. I am not talking about the diseases in post-transplant patients, that will come afterwards. Now, what will be the clinical manifestation? In acute graft versus host disease, the reaction is primarily seen in liver, skin, mucosa and intestine. Whereas in chronic reaction, it is seen in all these organs and also in connective tissues and exocrine glands. What are the connective tissues? It is the muscles, skeletal systems, predominantly muscles. And because it affects the exocrine gland, it will affect various systems including sweat glands. So, how can we prevent them? Main is glucocorticoid, because it is activation of immune system as a whole. Glucocorticoids inhibit the immune system as a whole. So, in graft versus host disease, the predominant therapy is by steroids. And this is what I am stressing upon. Within the first 100 days, there is a chances of graft versus host disease. Along with, we are giving therapeutically, we are giving corticosteroid. So, these patients have no defense against any microorganisms. So, post-transplantation up till 100 days, they are susceptible to numerous infective conditions. After this lecture is over, go and make a list of common infective conditions which occur within 100 days. Those are very significant. I've already told you these are the skin. They are categorized into grade 1, 2, 3, 4. You don't need to learn this by heart. There are 4 categories depending on the severity of how organ systems are involved. Okay. How to circumvent this? Nowadays, you will hear about hematopoietic stem transplantation. Now, bone marrow transplantation is generally not done. What is done is, suppose a patient who has no cell leukemia, we irradiate the marrow, so no more stem cells are present within the recipient. Now we transplant only the stem cell, not the whole bone marrow. Because we are transplanting only the stem cell, the chances of graft versus host disease are reduced. Understood? Earlier, because we are transplanting the bone marrow as a whole, the chances of reaction were much more. This is a graph, just try to observe this. This is the allele match. That means the donor and the recipient have same match. Over here you can see the red color line, the survival increases very much as compared to other matches till 6 to 8 years. And if we look at the graft versus host disease, here's the red line. It is the minimum graft versus host disease. If we look on the right hand side where there is class 1 and class 2 mismatch, the survival decreases and the chances of graft versus host disease increases. That means even though we are transplanting stem cell, matching is still very good. Finally, very short, I'll talk about cancer immunology. What is cancer immunology? That is study of antigens of the tumor cells and the immune response to those antigens. There are two types of antigen, one is the tumor specific and the tumor associated. What are tumor specific antigens? Tumor specific antigens are present only on the tumor cells and they are not present in normal cells. That's why they are called as tumor specific. And they induce cell mediated immune response. What are these? These are either chemical or physical carcinogen which induces the cancer, or it could be viral carcinogen which induces the malignancy. For example, ultraviolet ray or like Epstein-Barr virus, we will learn about when we study virology, which causes nasopharyngeal carcinoma. Tumor associated transplant antigens they are non-specific. That means they are expressed by cancer cells, that is fine, but they are also expressed by normal cells. Only difference is in cancer cells, their expression are very high. There are two types, oncofetal antigens and non-oncofetal antigens. Oncofetal antigens means these antigens are seen in the fetus and also in malignancy. Okay, but as a fetus goes into a child and become adult, these antigens are expressed but in very small amount. But if that human being develops any malignancy, these antigens are expressed in very high numbers. Example, alpha fetoprotein and carcinoembryonic antigen. Non-oncofetal antigen would be like carbohydrate antigen, prostate specific antigen, and macroglobulin. I think you know prostate specific antigen increases in both benign hyperplasia of prostate and prostatic carcinoma. There are many antigens and these are used as marker for diagnosis and management. When I say management, on therapy, the level of these markers reduce. This is the list. You don't need to remember everything. What I'm trying to say is they are used for diagnostic and for management. Because if therapy is adequate, the level of these antigens will decrease. Now, the immune response to tumor cells will be mediated either by humoral or cell mediated immunity, both antibody mediated and both cell mediated. Cell mediated is very important, mainly by cytotoxic T cells and natural killer cells. Cytotoxic T cells, again MHC class 1. I have already told you all nucleated cells will express MHC class 1. But in case of malignant cells, the expression of MHC class 1 will be altered. Now, cytotoxic T cells will get activated on these cells and they will cause direct cell death, cell lysis. Natural killer cells are not MHC restricted. That means it does not function with MHC. How it functions? Look at this. The inhibitory receptors of the NK cells will no longer function in absence of MHC on target cells. Activation receptors on the Fc fragment of the NK cells bind with the antibody coated cells leading to ATCC. Natural killer cells can be activated both by antibody and by non-expression of the আমি কি বললাম যে activity of NK cells is not compromised but enhanced by decreased MHC expression. Decreased MHC expression will trigger T cells, but because of the decreased MHC expression, the activity of the NK cells will also increase. And again, NK cells can be activated by antibody mediated. This is known as the antibody derived cytotoxicity. Finally, in cancer therapy, there are three types of therapy. One is cell-based, antibody-based, and cytokine-based. Cell-based therapies are the recent modalities. Multiple researches are going on. Basically, directing the NK cells and cytotoxic T cells to the malignant cells. This is known as the cell-based therapy. I have already told you monoclonal antibody will bind with the specific malignant cells and antibody-dependent cytotoxicity can be initiated by these monoclonal antibodies. There are many monoclonal antibodies like trastuzumab in breast cancer. You will go and learn in specific. Finally, cytokine therapy. What does cytokine do? What does cytokine do? Cytokines like interferon, they activate the natural killer cells for cytotoxicity. If the patient fails to produce, artificial administration of cytokines like interferon alpha will aggravate the killing of the natural killer. This is how immune-based therapy can be done. Finally, coming to cancer vaccines, vaccines can be given only for malignancies associated with infective conditions like HPV causing cervical carcinoma. You might know there is a vaccine for HPV. Similarly, hepatitis B can cause hepatocellular carcinoma. There is a vaccine for hepatitis B. So, any vaccine will actually prevent malignancy. Till now, I think only these two are present, hepatitis B and HPV. So, that would conclude the class. Thank you.